So much of, let me show you something. Let's just start with data. How about data? What we have here, each one of these red bars indicates when one person is interacting with the healthcare system. And we'll tell you a lot more about this data as we go forward. But this is over a period of a couple of years, and they have some interaction. They're getting assessed and evaluated by trained healthcare professionals. And this is all well and good. There's great stuff that can happen in a hospital, and there's great stuff that can happen in your day-to-day interactions with your healthcare providers. But yesterday, in fact, I was talking with Richard McKeon, who is the Fred Jelinek of the suicide prevention world. And he gave this fantastic talk yesterday about where we are most vulnerable. And so in the suicide prevention world, what they're calling the lethal gap is in between those red bars. The most dangerous day for a person who is at risk for suicide is the day after they get discharged, when they're not under the care of the healthcare system. So, well, this is prime motivation for what we're doing this summer, because we have other data sources that are outside of the healthcare system. And so what we're going to talk about today is the many ways in which we can take some data that is not relevant to the healthcare system and what we can tell about mental health from that. So this is one such user and their visits to the healthcare system and their Facebook posts. And so you can see some interesting patterns there. This person seems to at least, you can see, like, perhaps when a person is sick a bit, they're posting less. That's kind of interesting. There's some interesting temporal patterns here. We have 4 such people here. And you can see this sort of cluster into a couple of different groups. There's the person up top that seems to be well engaged with the healthcare system. There's the people in the middle that sort of maybe once a year are going there. And then there's the people like me that are not very good about going to the healthcare system, only go when they're hurt somehow. But in almost all these cases, you can see there's an awful lot more data that's available to us to do something with. Except for this guy. And that's more like my social media presence. I don't do a whole lot there. And so, yes, this isn't going to work for everybody. But what we're talking about today is what can we do with natural language processing, with computational linguistics that will help us fill in that lethal gap. So we've got 3 takeaways for you. I don't care if you believe them now. If you don't believe them at the end, let's step outside and we can discuss it further. But the first is that there's clinically meaningful information that can be derived from social media language. The second is that there are psychological trends that can be forecast from social media language. And the third, which is most important to me, is that there are psychologically meaningful events that can be predicted from social media language, like a suicide attempt. So, all of these imply something that we don't often do in natural language processing, and we have not done to date looking at mental health data, mental health social media data. Instead of treating these things like bags of words and effectively taking the marginals of those plots I had up before, what's a person's language sort of lumped together, because we all know how to hit cat, right? And put all the strings together and look at one long vocabulary. What we don't know quite as well is how do we model changes in time? It's very clear there are temporal patterns that are meaningful. And a lot of what we explored this summer is exactly that. How can we inject some time into what's happening here, and how can we better understand what's happening as a person changes, as their mental state changes? What can we learn through time? Which is more important than just binary, are they suffering from something or not? So if anybody has heard me give a talk in the last number of years, I usually end on this quote, but I wanted to start with it today, because it really does set the stage for what we're doing. The work here is foundational. It's a lot of validation. We spend a lot of time validating what we're doing and setting the stage for lots of work to come in the years following us. And so this is a quote from Alan Turing: "We can only see a short distance ahead. We can already see plenty there that needs to be done." And I don't know that all of you guys know this, but we lost Alan Turing to suicide. Can you imagine if he had lived further? How much more we would have all benefited from that? So I say this as motivation. There are so many brilliant people that we've lost to suicide, and there are so many quote-unquote normal people we've lost to suicide. This is a huge problem, and perhaps larger than any of you guys really realize, unless you've been here all summer, then you've heard me say some of these stats. So I'm going to tell you some uncomfortable facts about suicide. It's not a pleasant subject, but it's a really important one, so I want you to fully appreciate the motivation for what we're doing here. 1% of the population of the United States is expected to die by suicide. And so that's more than 40,000 a year. It's a lot of people. And to put this in perspective, more people die by suicide than by homicide, or by vehicle accidents, or by terrorism. And you guys can think of huge public campaigns that are looking at these things. Suicide is so ill understood compared to all of these things. And so that's a lot of the motivation for what we're doing here. Can we get a better grasp on what's happening and what's causing these people to die by suicide? So I've said a lot about suicide. We didn't just look at suicide. There's a lot of other mental health conditions that are wrapped up in this, right? We didn't take a singular focus here. We looked at a much wider array of mental health conditions. And so let's put some numbers on those stats. 1 in 4 worldwide will experience a mental health condition at some point in their lifetime. And 1 in 5 in the US will experience a mental health condition this year. This includes like substance abuse, depression, anxiety, PTSD. There's a wider range here, and that's an awful lot of the population. And for every one of those people it's affected, it's not just them, but it's their families, their friends, their caregivers. So this is a huge problem, and it doesn't have a whole lot of attention paid to it necessarily. Why is that? Why do we understand so little about what's happening in mental health, and why don't we talk about it? One of the big problems here is that we lack gold standards. I know it sounds like we have these labels that that clinicians talk about, like it's a thing, like PTSD is a thing. It is like here's the label that you've got. This is the thing that you're dealing with. But that's not really the case. The way that I'm not going to belabor this point. For those of you that saw April Foreman talk here, she talked extensively about this. But there isn't a really great gold standard diagnostic for a lot of mental health conditions. Most of what's been done in the mental health field is looking at things like the DSM, the Diagnostic Statistics Manual, which has gone through a couple of revisions, and this is effectively collections of symptoms that someone challenged by PTSD, for example, might exhibit. And so if you've got 3 of these 6, you then qualify for having the label PTSD. Or if you have 12 of these 18, you qualify for schizophrenia, or whatever it might be. And so these have been revised a couple of times, and to some pretty drastic results. So the definition for depression has changed really dramatically from the DSM's 3, 4, and 5. It's true for any condition. And this is because we're starting to understand more about some of these conditions, but we still don't understand enough. And so we see this as a really golden opportunity for natural language processing and computational linguistics. If all the interactions that so many of the healthcare system has with these people, when they get a chance to observe them and observe their mental health, if all of that is happening within the healthcare system, they have a very limited view of what's happening. They're not seeing where mental health really takes place, which is where they're interacting with the rest of the world. And so computational linguistics and social media and all this data outside the healthcare system has a chance to provide some of that information to the healthcare system and actually help us better write the rules for what the gold standards should be. So this is not a new idea, but with the ubiquity of social media and the fact that there is so much more language that all of us is generating and putting into place and storing digitally, the digital fossil record, as April Foreman is fond of saying, language really is, there's plenty of evidence it's an effective way, an effective lens through which we can study mental health. And so we're just continuing on that trend, and I think setting a pretty strong foundation for the future work that's going to build on these things. So what can you do if you have NLP related to mental health? I'm just going to talk about a couple of applications. This is far from an exhaustive list, but it's a start. The first thing most people think of is asking who's at risk for suicide. If we know who's at risk for suicide, surely we can go and save them. It's not so simple. So let's say that I could tell you everyone that's at risk for suicide in Baltimore. What do you do? What's next? How do you do that without violating their privacy? How do you find the clinicians that are skilled enough to help these people? There's a whole lot of problems that are wrapped up in this. So this is the obvious application, but in some ways is the least implementable. So let's talk about some other ones that are also motivated by this that might not be quite as obvious. There's a lot of room for diagnostics. We just talked about this a bit, and Rebecca Resnick, who is a member of our clinical panel, you'll hear a bit about her later. She spends a lot of time trying to do diagnosis and diagnostics on people to try to get a really fine-grained appreciation of what's going on and what it is that they're challenged with. And so she tries an awful lot to be able to do differential diagnosis, for example, and be able to determine whether or not this is bipolar or borderline personality disorder. Two very different things, but they manifest very similarly. Similarly, if we could tell you which therapies are working right now, is this a good therapy? Is this a good intervention for somebody? Likewise, unobtrusive measurements. If we can sit there and look at your social media data and tell you how you're doing, that's way less invasive than what they currently do, which involves structured interviews with clinicians to try to assess how well you're doing. There's a lot of possibilities for diagnostics. The next bit that I want to talk about is personalized medicine. There's been a lot of talk about this, and everyone seems to think that genetics is the key to this. Maybe that's true for physical disease, but I don't think that's true for mental health. We have the chance to, if I have a look at your Facebook profile, I probably can tell you some things about you. I can probably guess, for example, whether or not telling you to go outside and play Frisbee with your friends is something that you're likely to do. There's behavior encoded within your social media data, within a whole bunch of your data, but in this case, let's talk about the social media part, that can tell us what your life looks like. We're banking on that both to understand your mental health and to be able to suggest treatments that might best work. And so there's some personalization there that is ideal. What we'd like to do, given a little bit of heresy here, right? But those labels we've established are, they're not a gold standard. So maybe actually the right thing to do is to skip over them entirely and talk going from data directly to treatment, or data to intervention. It's a kind of radical idea for psychology because they've never had the data available for this. And so this is probably one piece of that that might enable us to do personalized mental health medicine. And the last is population scale analysis. We have access to lots and lots of data, public data, and if we have ways of turning that into things that can tell us about the population's mental health, we could really learn some things we couldn't know before. So one example is Robin Williams' suicide a couple of years ago. It's not clear what the reaction of the country was to that. We don't actually have methods in place that would allow us to measure that. Because the surveys that they take are phone surveys, and it takes many, many man-hours to go and call people and to tabulate these things, and the data comes out about 2 years after it's been collected. And so for some sort of temporal event like that might have had an effect on the public consciousness, we don't currently have a way to measure it. But maybe we do. Maybe this is a piece of that. So that's great, Glenn. Who the hell are you to say these things? You guys might not know that I have a degree in psychology, but I'm still not really a psychology person. Like, from many people's perspective, I'm a pretty poor psychologist. So we didn't trust my psychological judgment. We put together a clinical panel that has expertise in the more clinical research and lived experience side of mental health. And so with them in mind, we met with them every week and presented them some of our results. And so this is a great motivation to remind us of the importance of some of the stuff we're looking at. They had brought a very fresh perspective to what would otherwise be some pretty boring NLP plots. Well, actually, they're kind of exciting NLP plots, but grand scheme of things here. And they brought to us some psychological coloring that we wouldn't have had otherwise. And what does it look like when I'm dealing with someone who is at risk for suicide? So it was an absolutely wonderful addition to our summer. And so these are some of the wonderful people that took their time every Friday to sit down and chat with us and to give us their perspectives. And so you have people that are experts in suicide prevention, people that are sort of traditional academics within the clinical psychology, practicing clinical psychologists, and then people from the research side as well, epidemiologists, and people that are more traditional psychology people. And so we're fortunate enough to have one of those traditional psychology people here in Molly, Ireland, and I'm going to turn it over to her for a moment to give her perspective for these things.